Good evening, everybody, and welcome to tonight's Facebook Live session. My name's Sam Chakowski, and I'm the Sales Manager for Wound Care People. You'll be able to see that we are recording this remotely today, so please do bear with us if there are any technical issues. I'm sure there won't be, but we'll be working hard behind the scenes to fix them if there are any. Tonight's session is called Right Dressing, Right Patient, a Step in the Right Direction. And tonight we have Trudy Young speaking, who is the Director of Education and Training at the Welsh Wound Innovation Centre and also a tissue viability nurse at the Velindre Cancer Centre in Cardiff. Welcome, Trudy.
Thank you very much for the introduction, Sam.
How are you?
I'm fine, thank you.
Yeah, really looking forward to this session. I'm just going to run through a couple of quick bits of housekeeping before we get started, and I'll pass it back over to you. So firstly, the certificate link will be available at the end of the session. We'll pin that in the comment section as well, so you'll be able to download your certificate for CPD and revalidation. Also in the comment section, if you can send in any questions throughout the session, we'll get as many of those questions to Trudy in the live Q&A at the end. If we don't get through to your question, we will try and answer those in the next few days and post them on our website as well. So ask away, let us know where you're tuning in from, answer any polls as well that come up on your screen, and I will see you over in the question and answer session at the end. So I will now pass you over to Trudy to begin tonight's session, and I will see you later.
Thank you very much for the introduction, Sam. Hello everyone, I'm delighted to be joining you for this Facebook Live event, and I have been a tissue viability nurse for nearly 30 years, and it's a job that I love. I would like to thank Merlinecker for inviting me to present to you on this Facebook Live event. I'm going to introduce you to the concept of stepping up and stepping down in wound care. I will use wound EXUDATE as a working example throughout this presentation. On the screen are the learning points I'm going to cover during this presentation. As you can see, we will start with wound healing and then move on to wound assessment. Then I will introduce the concept of stepping up and stepping down. The last learning point is an overarching one that applies to all the topics I will be covering. During this presentation, as Sam said, a question will be posted and you can submit your answers through the poll on your screen. So let us revisit the wound healing process, which involves hemostasis, inflammation, destruction, proliferation, and maturation. Hemostasis is the body's response to injury and results in the formation of a blood clot. Once bleeding has stopped, the blood clots are broken down, and this process results in the release of platelet-derived growth factor. Growth factors turn on and off the stages of the wound healing process. And this one is the inflammatory response. Inflammation is a crucial step in the healing process as it kick-starts the physiological response. The subsequent release of histamine promotes vasodilation. An increased blood supply is essential to bring the white blood cells that will orchestrate the healing process and clean up the wound bed to where they're needed. The cardinal signs of inflammation have been known for many years and include pain, redness, heat and swelling. The redness is visible around the wound and should subside in about 3 days, unless another issue such as wound infection prolongs the inflammatory phase. In the second destructive phase of wound healing, some of the white blood cells that are normally contained within the circulatory system are able to leave the blood vessels and travel to the wound bed. They are assisted in their journey by the white blood cells in the tissues around the wound, in this case macrophages, who release a substance that is called a chemotactic factor. The purpose of this is to draw the white blood cells from the blood vessel to the wound bed. Once they arrive at the wound bed, the white blood cells phagocytose and destroy any non-viable tissue, such as slough and necrosis, along with bacteria and viruses, with the ultimate aim of cleaning the wound bed. Once the wound bed has been cleaned and prepared for healing, the formation of granulation tissue is the next step. In this proliferative stage, the white blood cell, the macrophage again, is extremely influential. It releases growth factors that stimulate another cell, the fibroblast. The fibroblast then increases in numbers and subsequently produces strands of collagen that form a basket weave structure in the wound bed. And this is the basis of the granulation tissue. The macrophages also release an angiogenic factor, and that stimulates a new circulatory system to grow into the granulation tissue and provide oxygen and nutrients that are necessary for wound healing. The formation of granulation tissue can take some time, and in some cases, for a large cavity wound, it can take many, many months. The formation of granulation tissue will depend on the size of the wound and the health and nutritional state of the individual, as protein is required to form the collagen matrix, and fats are required to produce the new blood vessels. You can see a good example of healthy granulation tissue on the screen. In a cavity wound, once the granulation tissue has reached the level of the surrounding skin, new epidermis is required to cover the granulation tissue. The epidermal cells at the wound edges release themselves from the underlying dermis and travel across the wound bed. This is seen as a progressing pink margin at the wound edges. Epithelial tissue is not always pale pink. In healing leg ulcers, it presents as white dots in the wound bed. This is where the epidermal cells generate from old hair follicle sites. So in these wounds, you may see a combination of a pale pink wound edge and white dots in the wound bed. I always make sure I share this information with the patient so they can see healing taking place in their own wound. Once a new epidermis has covered the wound, healing is still not complete, although it looks healed to the naked eye. The collagen that was produced to form the granulation tissue is replaced by a stronger collagen that can cope with the day-to-day activities of the human body, and this process takes many months. We must remember that wound healing is not always a linear process, going from hemostasis to maturation. As often, it is an oscillating route, with chronic wounds moving forwards and then backwards between the stages before eventually getting to healing. Whereas acute, uncomplicated wounds are more likely to progress in a linear fashion from the start to the end of the process. As you can see on this slide, we have exudate levels on the vertical axis of the graph and tissue types along the horizontal axis. The exudate is heaviest during the inflammatory stages of the healing process due to the increase in blood flow to the wound. However, as the wound heals, the exudate levels drop. You can see on the curve the lower rates of exudate for the granulating and epithelializing tissue, signifying the final stages of the healing process. Wound assessment helps us to recognise if a wound is progressing through the stages of the healing process, or if it has stalled, or even worse, is deteriorating. It's important to realise that wound assessment is not just about the wound bed. It should start with an assessment of the individual, taking into account their medical and nursing history. For example, any comorbidities and current medication. The systematic part of the wound assessment should ensure that every wound follows the same process and involves, as my colleague Professor Keith Harding would say, history, examination, investigation, and then diagnosis. As without a diagnosis, How can we instigate a management plan? I have mentioned things to note in relation to history, whereas examination involves not just looking at the wound, but at an individual's skin to identify any abnormalities and to establish the state of their skin. Investigations can include blood tests, looking at inflammatory markers. X-rays and MRI scans will be requested if there's a suspicion of osteomyelitis at the base of the wound. Ankle brachial, or in the case of diabetic patients, toe brachial pressure index, will assess the arterial flow to the foot. This list of investigations is not exhaustive, and a biopsy may be taken if malignancy is suspected. The documentation aspect of wound assessment ensures we share our assessment with the relevant people. It also helps us assess if the dressing regime has been the right one for the wound. So the documentation aspect is not just about form filling. It enables you to share the content of your systematic wound assessment with others. Which takes us on to the final part of the assessment process, the outcome. As clinicians, we have to decide if the wound is progressing, and if not, what are we going to do to facilitate this or prevent a backward step? This is a clinical decision and should be made at the end of every wound assessment. However, I would ask you all as clinicians, is this always the case? Or is the wound assessment form completed and the same type of dressing replaced without a thought as to whether it was the right dressing for the wound? We will look at some of the reasons for this later in this presentation. A small retrospective audit was undertaken in the UK. It was supported by interviews with nurses working in the acute and community setting and with tissue viability nurses. The aim of the study was to understand the reasons why nurses change dressings. The results highlighted that the majority of reasons for changing a patient's dressing is related to the need to inspect the wound or because of adherence to care plans, rather than being related specifically to dressing performance, with staff focusing on protocols and not clinically assessing the wound on every visit. Despite manufacturers producing dressings designed to increase wear time, these advantages were often overlooked by nurses contributing to the audit. Many staff felt that dressing changes were commonly determined by the frequency of the nurse's visit to the patient. And although many of the dressing changes could be performed less frequently, it was more practical and pragmatic to change a dressing during the patient visit. Another finding was that many wounds were treated with the same product family throughout the period of the audit. The audit highlighted task-orientated nursing practice, often due to a lack in confidence underpinned by a lack of education and training in wound care. Therefore, ritualistic practice was a consequence of limited knowledge, which often meant that patients were receiving unnecessary and inappropriate treatment that was unrelated to the clinical assessment of the wound. There was an over-reliance on tissue viability nurses to make the decision as to which dressing should be used, which resulted in de-skilling the general nurse and overloading the already stretched tissue viability services. The staff were said to be risk adverse, which resulted in them sticking with dressings they were familiar with, rather than choosing a dressing that best met the need of the individual and their wound. The results of this audit are a great concern. However, we must remember it was a very small study, which may not be a true reflection of the practice of the majority of nurses. Recently, during lockdown, I was redeployed to teach community nurses about wound care. And I can echo the findings of the research, as the nurses were very eager to receive education and training on Doppler ultrasound assessment and compression bandaging. They were very motivated and wanted to make sure their skills enabled them to provide the best care to the leg ulcer patients. Throughout my time as a TVN, I have witnessed many of the behaviours highlighted by the audit, with nurses having their favourite dressing and being unwilling to try anything new. As a TVN, I have had what some will consider many inappropriate referrals. And after discussing the situation with the staff, I realised they knew what to do, but lacked the confidence to act on their clinical decision. I was there to support the nurses rather than tackle a complex wound problem. I don't feel this is inappropriate if it builds nurses' confidence, as in the long run it should produce autonomous practitioners who will rely less and less on specialist advice. As I mentioned earlier, we are going to look into the concept of stepping dressings up and stepping down. So let's get on with that. Here we're going to investigate what stepping up and stepping down means. In everyday life, we step up and down. For example, we may risk stepping up to a Madras curry from a milder korma. When celebrating, we may step up from sparkling water to Prosecco. In later life, when our families have left home, we may step down or downsize to a smaller house or bungalow. We already use the concept of stepping up and stepping down in tissue viability. We will move patients onto a more sophisticated support surface should their pressure ulcer risk increase, and then step them down to a less sophisticated mattress as their clinical condition improves and their risk status reduces. If a patient has a circumferential venous leg ulcer and accompanying edema, we may step them up to a multi-component bandage system. Then as the ulcer improves, we will step down to compression hosiery. If a patient has a large abdominal cavity wound, we will probably use negative pressure wound therapy. And as the cavity reduces in size, we may step down to a single-use portable system or conventional wound dressings. So as I said, we are used to stepping up and stepping down in our everyday lives and in the field of tissue viability. I mentioned earlier that there may be reasons why a clinician may not step up or step down the dressing regime according to the needs of the wound. And some of the reasons are on this slide. Time can be a great pressure, especially if you're a practice nurse and only have 10 minutes to assess, treat and document the state of the wound. The life cycle of the wound is not always predictable, and you may choose a dressing you think will be suitable. Then in between the visits, the wound deteriorates and requires stepping up to a more absorbent dressing. You may not be familiar with the variety of potential dressings you can use. You may think all dressings of the same brand do the same thing. And this is not helped by a lot of dressings looking very familiar, especially in their packaging. You may be a healthcare support worker or a junior member of staff, and you do not have the knowledge, experience or authority to make the decision to step up or step down. You may be so stressed in your professional role, especially in these challenging times, that to make one more decision is one too many, so you carry on with the current dressing regime. So what can we do to facilitate stepping up and stepping down in our wound management? The first thing is to reflect on our own practice. At every dressing change, we must do this. We must ask ourselves, have I put the right dressing on the wound to achieve a moist wound bed, not too wet and not too dry? We need to have access to a range of dressings. For example, to cope with a dry wound bed, we can use hydrocolloids or hydrogels, whereas at the other end of the spectrum, we need highly absorbent foam dressings for heavy exudate, and lighter versions of foam dressings for when the exudate levels decrease. The team discussion is asking junior colleagues about the rationale that underpin their dressing selection, and asking a healthcare support worker what was the state of the dressing they removed and replaced. Education is always needed, and here the wound care industry can help us. They know the range of dressings inside out and can offer tips on how to apply and remove dressings and when to step up and step down within their product ranges. I perhaps should have put the last bullet point first on this slide. If a patient has a chronic long-term wound, they are often able to notice subtle changes. For example, when a wound infection is developing, and they may well know what's helped previously when a wound infection is present. If wound odour is a problem for the individual, we will have to consider why the dressing regime is not managing the problem. We can use charcoal dressings to try and cover up the odour and absorb the smells. However, it is important that we discover the cause of the odour. Is it wound infection that will require an antimicrobial dressing and antibiotics? Is it slough and necrosis that will require debridement? Or is it that the dressings are not being changed frequently enough and are left saturated and smelling? We need to work with the patient to address their worries and concerns. What may be a wound care priority to us may not be the number one concern for the patient. To achieve this, we have to actively listen to the patient and use our communication skills to engage in a therapeutic conversation. Patients are a very valuable source of information and advice, especially if there is not a lot of continuity between visiting clinicians. So let's look at my own practice, and when do I step up to either a larger or more absorbent dressing? Definitely if a patient develops a wound infection, as I know the exudate levels will increase. If a patient has edema, but for whatever reason is unable to use or tolerate compression therapy, I will need more absorbency and maybe start with low levels of compression and build it up. That is, if the arterial status of the patient allows me to do so. If the wound suddenly increases in size, I will have more exudate coming from the wound bed. An example of this is pyoderma gangrenosum. This is an autoimmune disease that can produce a rapidly spreading ulcer, often on the lower limb, which is exceptionally painful. Straight away, my wound assessment would indicate that this is abnormal. I will need help from my medical colleagues who will use medication to try to arrest the abnormal inflammation in the wound bed. And as we discussed earlier, inflammation brings with it vasodilation and an increase in wound exudate. For the patients I work with in the cancer centre, they often will have malignant wounds, and these can be visually very distressing. Most people with cancer never actually see the cancer itself, but with these wound types, the cancer is there for all to see. So if by using a more absorbent product, I can reduce the frequency of dressing changes, I can help to alleviate the stress of seeing these disfiguring wounds. If during my wound assessment, I notice maceration of the peri-wound skin, it would indicate to me that the current dressing is not managing the exudate, and more absorbency would be required, along with a barrier product to protect the surrounding skin. So conversely, when would I step down in my dressing regime to a smaller or less absorbent dressing? Once the wound infection is resolving, usually, as I said earlier, following treatment with systemic antibiotics and topical antimicrobial dressings, I will be able to step down to a less absorbent dressing. As the wound travels along the healing process, from the proliferative to the maturation phase, the exudate will reduce and a less absorbent dressing will be required. Stepping down decisions will come after reflecting on the wound assessment and inspection of the dressing I have removed, as that will tell me a lot about the exudate levels, especially as we have no objective way to measure wound exudate, unless that is negative pressure wound therapy is being used. Interventions can reduce the exudate levels. One of the best examples of this is the use of compression therapy. It can be in the form of multi-component bandages, elastic and inelastic bandage systems, hosiery and hosiery kits, wraps, and the new innovative thigh intermittent pneumatic compression garment. I think it is important to remember the language you use when communicating with patients. When I am talking about compression, I do not use the term tight bandage, as this implies pain and discomfort. So I talk about a supportive bandage or garment, and always emphasize that the benefits of compression therapy are a reduction in edema, less frequent leaky legs, and less frequent dressing changes. An adjunctive therapy that reduces exudate levels is palliative radiotherapy. We tend to think of radiotherapy as curative. However, in the palliative setting, a single dose can definitely help to reduce exudate levels, and I have used it very successfully in patients with malignant breast wounds, allowing me to step down to a less frequent dressing change and less absorbent products. So hopefully I've convinced you of the benefit of not only assessing the wound, but also assessing if the dressing choice is appropriate. Let's look in more detail at some additional changes. The following might not be a change for yourself, but as I have already alluded to, we have to encourage less experienced and less confident colleagues to actively participate in wound assessment and to utilise their clinical judgment, albeit with support from more experienced colleagues. As without this, they will never expand their assessment skills and be able to integrate stepping up and stepping down approach into their wound care practice. I'm sure a lot of you will have wound care formularies in your health organisations, which guide your choice of wound products. However, do they give you guidance on stepping up and stepping down? If not, perhaps mention this to your tissue viability nurses or medicines management team, as by adding this advice, it can help you with your dressing choices. We know the potential benefits for patients by making the correct choices, and by stepping up and stepping down, we can prevent the unnecessary use of inappropriate dressings and use only the minimum viable product required. This will minimise waste and unnecessary cost, which in time will help our health organisations make financial gains. During this pandemic, we all have questioned the way we provide wound care, and there has been an increase in patient self-management. This will continue to be a successful strategy, so long as it is accompanied by guidance for patients related to changing the wound management regime, should the exudate levels increase or decrease. Technology exists that can help both the healthcare professional and the patient. For example, there are dressings that have inbuilt exudate progress monitors, which indicate when the dressing is reaching its maximum absorption capacity and requires changing. Wound assessment apps are being developed, and they will help share the wound assessment amongst those that need to know the outcome of that process. Again, according to my esteemed colleague, Professor Keith Harding, there is a difference between a wound dressing service and a wound healing service. A dressing service will only redress the wound and is driven by process, therefore redressing as many wounds as we can in a given time period. An example of this is when in the past I worked with a colleague in a dressings clinic, and she said she was never asked to help a wound to heal, but purely to redress the wound, which she did very well. Whereas a wound healing service is about outcome, and to achieve positive outcomes, we have to incorporate wound assessment alongside a stepping up and stepping down approach. So we may do fewer dressings, but produce better outcomes for the patient. So I would ask you to reflect, do you provide a dressings or a healing service? Hopefully this presentation will help you move a dressing service into a healing service. In my own clinical experience, this involves a multidisciplinary team, like the one we have in the Welsh Wound Innovation Centre, that involves nurses, doctors, podiatrists, orthotists, etc. Although I do appreciate that not everyone is able to work in such a diverse team, with so many skills available to help diagnose and treat patients with wounds. That said, as we know, dressings do not heal the wound. They help to minimise symptoms, and optimise a moist wound healing environment. Wound healing is performed by the individual and the underlying healing capacity. I hope this session has achieved what we set out to do at the beginning. We have revisited wound healing and reminded ourselves of the physiological complexity of the healing process. We have looked in depth into wound assessment and all its various components. That results in us being able to make a diagnosis and then provide a treatment plan to address the underlying cause of the wound. Hopefully, I have explained the concept of stepping up and stepping down when choosing our dressing regimes. In my experience, nurses find it easy to step up when exudate increases, but are less likely to step down and miss the opportunity to use lighter and smaller versions of products. Once I have completed a wound assessment, I always write in the medical notes. When asking for dressings to be prescribed, I state the size required, as otherwise it's always a 10 by 10 centimetres that's prescribed, and this may be too large and not suitable for the patient and their wound, as well as a waste of money. And I would urge you to reflect on the last bullet point in this conclusion. So here we are at the end of my Facebook Live presentation, and I hope the message on the screen now resonates with you. It is very unusual for a wound to be dressed with the same product from its inception to healing. And we need to make stepping up and stepping down an automatic part of our clinical decision-making process. It helps to build confidence with our patients. If they know we have the knowledge and access to dressings, we can step up to should there be a problem. And as I said earlier, we can provide hope and positivity when we step down in our choice of dressings. So thank you very much for your attention, and I look forward to taking your questions.
Brilliant. Thank you. Thanks very much, Trudy. That was really, really interesting and absolutely brilliant session. And I can see by how many people we've had watching this evening. I think it's one of our busiest ones ever, and we've had lots and lots of comments and questions come in as well. So we'll move straight over onto our real-time question and answer session, if that's okay. Everyone who's watching, please do remember you can still submit any questions through to Trudy. We'll get as many answered as we possibly can. But if we don't get through to your question, then we will answer those in the next few days, and we'll post the link to that on our website as well. Okay, so moving on to our first question. So Trudy, when would you recommend changing from a super absorbent to a foam dressing or to a lighter foam?
I think this is an important thing to do. I mentioned earlier that people don't step down necessarily. And it's about the levels of exudate that you find with your patients and their wounds. So super absorbents are high exudate. Then we should go down to the foam dressings. But as the exudate reduces, the lighter foam dressings are really helpful in managing the exudate when you don't need those super absorbent products. And as I said earlier, cost is important. That the lighter foams will not cost as much, but they will manage a smaller amount of exudate. So always focus on your exudate levels, but don't just think of exudate as super absorbents. Exudate management is super absorbents, ordinary foams, and lighter foams. We have three things there that can help us. So we need to make sure that we don't just use the top ones for heavy exudate, but we need to come down the ladder, step down and get good use of super absorbents, foams, but also of those lighter foams that can manage that less exudate, but keep that nice moist wound bed.
Brilliant, thank you. So question 2, we have a question from Gail here. Do you have a recommendation for an assessment tool for patients with ethnic and black skin tones?
Yes, I do, Gail. Yes, I do. I've been looking into this recently myself. So I have been looking at this. If you look at the International Pressure Ulcer Prevention and Management Guidelines 2019, when they're talking about assessing the skin, especially to identify category 1 pressure damage, non-blanching erythema on darker skin tones, they recommend the use of the Munsell colour chart. And the Munsell colour chart helps you detect these early changes in pressure ulcer development in darker skin tones. So I'd urge you to go to the international guidelines that were produced by EPUAP, NPUAP, and the Asian group, and have a look at what they say about the Munsell colour chart. And I found that really helpful. Also, there is a book coming out soon about assessing skin in darker skin tones, and that all will also should be quite helpful to us.
Brilliant, really informative, thank you. Question 3, we don't have a name for this one, but this one is, what would you consider when treating a diabetic ulcer?
Ooh, again, I have to refer back to my colleague, Professor Harding. Diabetic foot ulcers are really, really complicated. You have an immune compromised patient. They don't display the same signs of infection as you or I would. So you can have infection present without it visually looking like an infected wound. So what we have to take great care in diabetic foot patients is making sure that we've covered infection. Because they don't show visually in the same way, we monitor these through the blood tests, through the inflammatory markers. Have we got raised CRP? Have we got raised ESR? Have we got raised white cell count? One of the earliest signs of infection in the diabetic foot is a raised blood sugar level. So we need to monitor those. So those things are part of the assessment process in diabetic foot. As for the management, it depends on what's caused the diabetic foot ulcer. It could be motor neuropathy, sensory neuropathy, autonomic neuropathy, or peripheral vascular disease, or any combination of those three. So we need to know which has been the problem so we can address it, because they're all different. For motor neuropathy, what we look at here normally is footwear, because we have abnormal loading on the foot. So we need to use insoles, we need to use bespoke footwear to redistribute the pressure across the diabetic foot. If it's sensory neuropathy, these patients can't feel. And when you can't feel, you're not aware of injury to the foot. So in that case, it's about protecting the foot. So making sure people check inside their footwear before they have their shoes on. Make sure their footwear is correctly fitting. Make sure when they're on holiday, they don't take their shoes off and walk on hot sand and burn their feet. So sensory neuropathy is very different from motor neuropathy. In autonomic neuropathy, we have here a foot that is very dry, and you get cracks in the heels of these patients. And once you get a crack in your skin, as you know, bacteria invade. So we need to keep these feet moist and supple with the use of emollients and check them regularly for any breaks. If we have peripheral vascular disease, we need the vascular surgeons. And this is where that larger team in Wick comes to place, the Welshman Innovation Centre, because we have vascular surgeons, we have orthopaedic surgeons, we have dermatologists. Because until we can improve the blood supply to that foot, that wound is not going to heal. So we need vascular assessment with the Doppler ultrasound machine, and then maybe afterwards duplex assessment, then referral to the vascular surgeons, who if they can reconstruct that vascular supply, then we might go on to healing. Unfortunately, in diabetics, that's not always possible, and we have amputation as a result. But as I said before, we can have motor neuropathy along with sensory, along with autonomic, along with peripheral vascular disease, or any of those in isolation. So going back to the history, examination, investigations and diagnosis, as Professor Harding would say, we've got to know the cause. Because until we know the cause, we can't set the right treatment in place. And as I've explained there, the treatments are really different from footwear to vascular reconstruction. So diabetic feet are very complex. Podiatry in the UK lead the way. And we've got some really good new international guidelines on the assessment and management of diabetic feet. And I'm sure that you'll be able to provide the link to those later on after the presentation, Sam.
Yeah, definitely. So we'll post those links in the comments section. You should be able to all see those. And thank you so much for that answer. Really in-depth answer to that question. So thank you very much for that, Trudy. We have plenty more questions coming, so I'll quickly move on to the next one. This one's from Jane Smith, and Jane asks, what are your views on overusing antimicrobial dressings?
Oh, there we are. How long have we got, Sam? Yeah. Antimicrobial dressings have a place, especially in the diabetic patient where they're immune compromised, in my patients in the cancer centre where their immune system is poor. We need to protect these patients. So I think certain patient groups fit more readily with the antimicrobial dressings. When the antimicrobial dressings came onto the market, I'm talking mainly here of the silver dressings, we used perhaps too many. As nurses, we never want to cause our patients harm. We always want to keep them well. So we used antimicrobial dressings indefinitely. I mean, I heard stories of patients having antimicrobials for 6, 12 months. But if you think about it, like any dressing and any wound assessment, going back to my presentation, we need to reassess. So what the general consensus is now, and this is a consensus from the International Wound Infection Institute, again, we can share the link, that says if we use antimicrobial dressings, it should be for a particular reason, normally to assist with systemic wound infection, but we need to review, and we need to review at 2 weeks, if not sooner. And then we need to say, have we still got that same problem there? And if we have, is our antibiotic regime right? Is our antimicrobial regime right? So I think we need to use them. They can be a great help to us in dealing with immune compromised patients and protecting them, and in also helping to combat wound infection. But like anything, we have to review and reassess. And the 2 weeks is seen as the accepted time span for reassessing our use of antimicrobials.
Okay, brilliant. Thank you. So moving on to question 5. This one's from Beverly Morris. How would you recommend treating overgranulation and hypergranulation?
Okay, if it's a Beverly Morris that I know from North Wales, hello Beverly. Right, now, overgranulation, hypergranulation. So first of all, it goes back to, again, what Keith says, what is the cause? There's no set theory written down about overgranulation or hypergranulation, but what we tend to think is that we have abnormal inflammation. So when I talked about the wound healing process, inflammation normally should stop at about day 3 and move on. If you've got something that perpetuates the inflammation, such as infection, you get abnormal and extended inflammation. And then when we get to the granulation phase of healing, this abnormal inflammation we experienced earlier tends then to produce this overgranulation, where the granulation tissue continues to grow above the level of the surrounding skin. The other thing that we know is that if we have a device inserted into our skin doesn't like it. Our skin is intact. We like to be intact. When it's not intact, from here, we go into the mucous membrane, such as the mouth, as I said. If we have a break in our skin due to a tracheostomy tube, a PEG site, a suprapubic catheter, the skin does not like that. And the skin will mount an inflammatory response to try and reject that substance that's gone into our skin. So here you've got abnormal inflammation due to something being in our skin that shouldn't be there. So ideally, what we would do is remove that particular substance. But in the case of a tracheostomy or a PEG site, we can't remove it. So we have to deal with this abnormal inflammation. And if you think back, we have anti-inflammatories, we have steroids, they're anti-inflammatories. So where we've got this abnormal inflammation, we may use topical steroids, which normally we would not use because they delay reepithelialization. But if we've got a tracheostomy or a PEG, the topical steroids can actually help dampen down the inflammation. If you look at hypergranulation, it's normally quite spongy, quite wet tissue. So here we can use the foams and probably the lighter foams because you've not got a lot of exudate, but these lighter foams will absorb the exudate that's in this wet hypergranulation tissue. And by absorbing the exudate, the tissue itself will shrink down because the water content has been removed. So that's another option we can use. If it's wound infection, such as you see a surgical wound with a slight amount of overgranulation, normally at one end of the suture line or the other, the same principles would apply. The topical steroids or the foam dressings, the light foam dressings, to absorb the water and reduce the overgranulation. Sometimes, though, people get too concerned about overgranulation, and I found in my experience, if it's only minimal, the body's not daft, and just give the body time and it will deal with that itself.
Yeah, brilliant. Thank you. Question 6 is a quite topical one. It's looking for your thoughts on this, really. So the question is, promoting self-care for wound management, one of the few positive outcomes of the COVID-19 pandemic. And what are your thoughts on that comment?
I think there are two things on that. There's positives and negatives, Sam, like anything. When the first wave of COVID hit, I think we were all very, very frightened. None of us knew what to do. None of us knew how to keep ourselves safe, our families safe, our patients safe. So straight away, we discharged a lot of patients from our books and left them to self-manage. Now, as a patient with a wound, that must have been a very, very frightening situation to be in. But the wound care industry, along with yourselves, have come up with lots and lots of advice and guidance on how to manage your own wound. And the National Wound Care Strategy in England has got marvellous advice and resources for patients on how to manage their wound. And that's okay if you can take that on board. I had a patient recently who was having to self-manage, and he couldn't read. And a lot of the advice was visual and needed reading, but there was some out there that was okay for illiterate people. So I think we have to bear in mind that the advice we give needs to meet lots of different patient needs. Not one answer will suit everyone. So I think we need to build in diversity into the advice and guidance we give to patients. I know our own doctors in our WIC clinics were actively risk assessing our patients. So who could manage and who couldn't manage? And if they couldn't manage, what level of support we gave? I'm sounding a bit like the governments now. We gave different tiers of support. So some people, it might be a weekly phone call. Some people, it might be step by step, talking them through the dressing changes. So we risk assessed our patients. And I think we're going to have to continue to do this because patients are going to have to continue to self-manage, especially now we're in the second wave. I heard recently that a colleague, an acute tissue viability nurse in a health board in South Wales, was having to leave the tissue viability service to go and work on a COVID ward. So the tissue viability services that are there to support patients are going to be dramatically reduced. So I think self-management is the way forward. Because I also think as a patient, if I can manage myself, I'm not relying on having to wait in for nurses to come. I can be more proactive, I can take more responsibility, and I can learn more about my wound and what I can do to help. And I think lymphedema in Wales are an especially good example of this. The lymphedema service really promotes self-management and say to people, hey, this is what you need to do. But should you be struggling, come back to us and we can support you even more. So I think about self-management is not just a straightforward issue. It's about risk assessment, it's about the resources, and it's about that relationship with the patient that might ebb and flow depending on their ability to self-manage at any one time.
Yeah, absolutely. I completely agree. So I think we have a little bit of time. We've got plenty more questions. I don't think we'll be able to get through all of them. So as I said earlier, we will try and answer all of the questions that aren't answered in this live Q&A in the coming days. And we'll post a link to those answers on our Facebook page as well. So keep an eye out for that. I think we'll have time for at least 3 more questions anyway. So this one is from Laura Fuller. And Laura asks, how long would you recommend a primary dressing stays on a static wound bed before trying a different one?
Oh, that's a tricky one. That's a tricky one, Sam. Thank you for the question, Laura. This very much depends, doesn't it? The first thing I would be saying, and I always try and turn this around, it's not about the dressing, it's about the wound. So if the wound is static, why is it static? That would be my question. If I've got the right history, if I've got the right diagnosis, and I put the right plan of care in place, I would not expect a wound to be static. I would expect it to progress. So if it's not progressing, I might need to go back to say, have I got the right diagnosis? Which is what Professor Harding has taught me. I think as nurses, we chop and change dressings far too often, and I'm sorry if I offend by that statement, but we'll have one nurse go, and where I work, in our community in the UK, we don't have the luxury of the same nurse going to the same patient subsequent times. And that's why our assessment needs to be so good. So a nurse can read our assessment and say, right, it's like that then, this is what it's like today. Because they haven't seen the wound perhaps for 3 or 4 weeks, so they don't know. So when they see a static wound, quite often the automatic knee-jerk response is to change the dressing, thinking that the dressing will suddenly stimulate this chronic situation. When in fact we need to do the two. We need to check our diagnosis is correct and our treatment is correct, rather than knee-jerking, going from dressing this, dressing that, dressing this, and maybe a bit of iodine underneath for good luck. So it's about the quality of the assessment and matching that to the dressing that's been applied, and what would you as a nurse expect to see, and how many days would you expect to see a change following the change in wound. But just to change the dressing every time because we don't like that one, we want to try this one, we want to try that one. A lot of the time we're trying to get healing to occur for the patient, so we're doing it with a good intent and a positive way forward, but it sometimes becomes so so frequent that it doesn't allow a dressing time. So I can't say to you, Laura, it's 1 day, 2 days, or 3 days. But what I can say to you is if I put that on now, by such a day, I would expect to see such a change. So if I had dry necrosis and I used a hydrogel, I definitely would expect to see within 7 days softening of that necrosis. So I would always make sure my assessment is accurate, my aim is clear, then I can assess if the dressing has met my aim, and then if not, review.
Brilliant, thank you. So question number 8 is, do you think people tend to not step down wounds for fear of litigation?
I don't know if it's litigation. I think sometimes they don't want to step down, a bit like the antimicrobial debate, because if they keep with the top most absorbative dressing, it's going to be the best. But it's about those psychological changes. It's about saying to a patient, look, your wound needed a 15 by 15. Now it only needs a 10 by 10. You know, we might think, oh, I'm going to leave the 15 by 15 just in case. So not litigation as in being sued, but just worrying that we might let the patient down, when in fact we have to balance that with not giving the patient the positives of actually saying, great, we actually need a lighter version, a smaller size dressing that shows healing for you. So I think it's about making sure patients are safe, because that is our prime concern at any time. But where we can, as I said in the presentation, question ourselves, do I still need that size? Can I move down? Can I move to a lighter version and still keep my patients safe? But I don't think it's necessarily about litigation, but that's a personal opinion, like all the answers to these questions are, Sam.
Okay, brilliant, thank you. And that moves us on to our final question. So question number 9 is from Gillian Garrett, and Gillian asks, any tips on assessment of pain in wound healing?
Oh, I don't know if I've got tips, but it's essential. It's essential.
Yeah.
Most patients, when they come to us as nurses, they want us to take their pain away. And anyone who's had chronic pain or even acute pain knows how debilitating it is. So we have to assess pain. But if we just say to a patient, using a pain scale of 1 to 10, where is your pain? We write it down, but do we actually do anything about it? It's going back to our assessment process. So we need to do this on a continuous basis. And sometimes this is where a patient diary can help, or a pain diary can help, because we see them for a short period of time and they might not have pain at that moment in time. So say to us, no, it's fine. But they might go to bed that night and, due to arterial disease, have a tremendous ischemic pain. They might have to get out of bed and dangle the legs out of bed. They might sleep in the chair for the pain. So we need to know more than 1 to 10. We need to know when is it occurring in a 24-hour period. We need to know how often is it occurring in that 24-hour period. But we also need to know the nature of the pain, because there are 2 types of wound pain. One wound pain is nociceptive. And if I came over to you now, Sam, which would be a task over the internet, and gave you a slap, it would hurt. But maybe after an hour, you might forgive me because the pain would have gone away. So that's a normal pain response. So a stimulus, the slap, the body responds with pain, but in time, that pain goes away. And that's like surgical wound pain. The other type of pain we have is nociceptive pain, and that's neuropathic pain, when we have abnormal pain responses due to abnormal stimulus of the nerve supply. So in this situation, we could take a patient's dressing off and expose the wound to the air, and just the slightest draft on their wound bed would have them screaming in pain. And that's because the abnormal nerve system is sending the wrong messages to the brain. So what should be a painless experience turns out to be an exceptionally painful experience. Now, the way we treat nociceptive pain is the World Health Organization pain ladder that starts at the bottom with paracetamol and works up to morphine. If you had nociceptive pain, which is the abnormal nerve system, morphine I could give it you for forever and a day, and you would still have the same pain. For these patients, they need pain relief that works on the nerve supply, such as pregabalin or gabapentin. So the assessment is about the frequency of pain, the time of day, and the type of pain, and also whether the analgesics are working, because you might think they're on pain relief, so it should be okay. The way patients describe nociceptive pain is different to the way they describe neuropathic pain. So neuropathic pain would be pins, needles, sharp, stabbing, like an electric shock. So again, you get an idea when listening to your patients of what type of pain it is. Nociceptive pain might be pain due to dressing change, which we know is the most painful type for our patient. But they also might have the both. They might have neuropathic pain and nociceptive pain. So neuropathic pain, we have to address with the right medication. And nociceptive pain, we might have to look at our dressing regime, using atraumatic silicone dressings that don't cause trauma on removal. How do we cleanse that wound? Is it very, very gentle? Do we expose the wound bed for the shortest amount of time? So there are lots of things we can do, but our assessment is not just a 1 to 10. It has to be more than that.
Brilliant. Thank you. Thank you so much for answering all of those questions, Trudy. I'm not quite sure I'd forgive you that quickly if you were to slap me, but I would eventually, I'm sure. Thank you so much for your time tonight. Really, really interesting session, and thank you for answering so many of our questions. I know that the comments have been coming in praising the session as well, so you should give them a read at some point as well.
Thank you, Sam. And can
no
I also thank the audience for being so participative, because their input makes the session, I think, a lot more rich and valuable for people.
Absolutely, absolutely. Thank you, Trudy. So this concludes tonight's live training session. Again, I will thank you all for joining in and engaging so much in the comments section. I'd also like to thank Trudy again, and finally, I'd like to thank Molnica as well. Thank you, Molnica, for your support for this event. Without you, we wouldn't have been able to put on this event for free. So big thank you. All of their contact details should be on the screen for you now. Do get in touch with them, make the most out of their resources. Contact the Molnica clinical support team if you have any questions, and follow those links that are on the screen. They'll also be put into the comment section as well for you. So your certificate link should now also be on the screen. You can download that CPD certificate for your revalidation portfolio. That'll be pinned into the comments section too, so if you do miss it on the screen, it will be available there, so keep an eye out. Also, don't forget to like the Facebook page for Wound Care Today. We'll be posting all of our future events on there, so if you like and follow us, then you won't miss any of our future Facebook Live events. So thank you very much all for joining us. Have a lovely evening, and we will see you all next time. Thank you very much.